Yep. Thank you. Hi there. Hopefully everyone can hear me. Do you want to just say if you can hear? Just type into the comment box. Fantastic. Okay. Whoa. Good. Welcome everyone back to the COVID cases learning. So the session's for junior doctors, staff grades and consultants. And also we're welcoming this week doctors from NELFT and from Norfolk and Suffolk NHS Foundation Trust. So the idea is to do some thinking together about scenarios that we're likely to meet during the pandemic. It seems like a very long time since we met a week ago. So we've all lost quite a lot of the structure of our lives and our ability to plan for the future. Some of you are in new roles, working more days, struggling to work from home, juggling childcare, worrying about family. Our patients are vulnerable, and so are we, and so are our colleagues, and it's difficult. But in the last week, many of you have gained lots of knowledge and confidence about COVID from seeing symptomatic patients. So I want to thank you for joining us today to share your thoughts and experiences. I also want to thank this week's peer reviewers, David Bridle, Becks, Lingard, Tom Wlker and Delphine Solomon. Most of all, I want to thank Cate Bailey and Lynsey McApline for putting so much work into the presentations. We all have concerns, I think, about how to look after our patients with coronavirus and also how to look after ourselves. Junior doctors, please do continue to raise your concerns. They are being heard. Please do make suggestions as well about cases and dilemmas that you'd like us to cover in the coming weeks. So the webinar from last week's session is accessible. The link is in these slides. And this week we have the same format. So it's a 45-minute presentation with your comments, please welcome throughout. And we'll have a Q&A at the end as well. And we're looking today at the acute admission of an unwell patient, looking at seclusion review and managing intrusive behaviours. So over to you guys.
Very much. Okay. All right, so welcome back, guys, for week 2 of our COVID cases. We can probably just click through this, can't we? Yeah, at least it started with an update on last week's case.
So very helpfully, which adds to kind of what we talked about last week with someone who's on clozapine, there's now some Maudsley guidance, and there's a link in our slides. So that's been very helpful. Essentially, it kind of was in keeping with the advice that we gave, but there's some new research that's come out kind of about what can happen with COVID and lymphocyte counts, which can lower the total white cell count. But the guidance really suggests that as long as the neutrophils are okay and the monitoring continues, it's okay to continue clozapine, but worth having a look at that. There's a lot of detail from the Maudsley there. And then the Resus Council guidance that we referred to last week, it's kind of, you know, in keeping with the idea that CPR is an aerosol generating procedure, so that full aerosol generating procedure PPE should be worn. So that's the FFP3 masks that we also talked about last week. So that needs to be worn before commencing CPR.
All right, and just one other update as well. I think as of next week, we'll be running this webinar from 1 o'clock, 1 till 2, is that right? Yep. So just take a note of the different time from next week. All right, so on to our next case then. So our next case is a lady called Miss K. So in this scenario, you're the night SHO on call, and you get a call from the senior nurse about Miss K, who's a new patient currently in the place of safety, who's likely to be admitted in the near future. So she's 29, she's been trying to get access to the medical unit, telling everyone that she's got special powers and can cure all of the patients that have been admitted. Hospital security called the police. When the police arrived, she was grandiose, she was irritable, she was threatening the police, and they decided to put her on a 136. So the senior nurse calls you and says that the Ampony Independent Section 12 doctor are already here, but they can't get hold of the on-call SPR, they're stuck at another site and won't be able to attend for a few hours. The DSM wants to check with you about the new amendments to the Mental Health Act. They say, is it true that we only need 1 med rec now to detain someone in Section 2? So what are your thoughts, guys?
So we're asking about whether or not it's okay to detain someone with 1 medical recommendation, and the So lots of comments coming in. So it's being proposed but not implemented, not yet finalised. Lots of ideas. So essentially, the upshot is not yet. Yeah, so I think we can move on.
Yeah, so it looks like all the comments are kind of in keeping with what we've said here. So the DSM is talking about the new Coronavirus Act that was passed into law about a week ago, which is proposing a couple of changes to the Mental Health Act to reduce the burden on healthcare workers during the coronavirus crisis. Now, these changes are not enforced yet. The idea is that they put these in as an act of parliament that can be activated later on if pressures worsen and if the situation gets worse. But the things that they have included are that we only require one doctor in an AMP to detain someone on a Section 2 or 3. They've extended the duration of 5.2s and 5.4s, and they'll be extending the duration of Section 136s as well. And I suppose in the longer term, it's worth bearing in mind that they're taking away the need for a SOAD review at 3 months. But just to reiterate, these are not in place yet. This is stuff that might be activated further down the line. So that's the advice you'll be giving to the senior nurse when they're on the phone to you. All right, so you reassure the senior nurse, and the on-call SPR manages to get to the place of safety a few hours later and completes the recommendation. The patient is still being quite aggressive towards staff, and so once she's been sectioned, they make the decision to transfer her straight into seclusion. They use high holds to walk her into seclusion, but she doesn't need any restraint, and you get called again, asked to come and attend a seclusion review. So before you go to the seclusion review, you have a good look at her notes just to get a sense of what's going on with this lady. And you see that she's got this background of bipolar affective disorder. And you see that she's had 2 admissions in the past under the Mental Health Act for manic episodes. So 6 years ago, she had a postnatal admission and was treated with olanzapine and did really well on that. And then 4 years ago, she stopped the olanzapine because of side effects. She had a relapse and was admitted again, but was stabilised on lithium and has been managing quite well in the community on lithium since. We're not sure from her recent history whether or not she's been taking her lithium. We can see in the notes that she had her last CMHT appointment 3 months ago and seemed to be totally well at that point. But otherwise, there doesn't seem to be any concerns recently. And you see that on her notes, she's got a history of asthma, but no other significant medical history and no allergies. All right, so the first question on everyone's mind is, does this person have COVID? And the nurses in this scenario have quite rightly asked some screening questions so they can tell you a bit about her background and her risk. So she's told the nurses that she's in close contact with her daughter, who's had a cough and a fever for the past 5 days. She tells us that she's been exposed to coronavirus, but she's completely immune to it. And she reckons that this immunity means that she has special powers so that she can go and cure everybody else and end the pandemic. The nurses haven't been able to check her temperature or any of her other obs because she's quite agitated, but they have noticed that she's had a dry cough since coming in on the 136, and they noted that she did try and spit on one of the nurses when they transferred her into seclusion. All right, so I thought we'd get started just by thinking about, is this a suspected case of coronavirus? What are your thoughts, just having a look at these risk factors here?
So lots of yeses, pretty much unanimous, and a suggestion to isolate her. Yeah, so we're kind of thinking about, is she suspected, is she possible? And we're going to talk about some of those definitions shortly because it's a bit confusing.
Yeah.
But I guess at the heart of it, we think she could have it, and we're going to act accordingly.
Yeah, certainly we've got that concern. So just having a quick look at the case definitions. So these are the case definitions from the World Health Organization. It is worth noting that Public Health England has quite similar definitions, but they don't include the need for travel to an affected area. But if we look just at the World Health Organization, they have the definition of a suspected case, a probable case, or a confirmed case. So a suspected case is one where the patient has an acute respiratory illness and a history of travel within an affected area in the 14 days. Or patients that have had acute respiratory illness and contact with a confirmed or probable COVID case. Or someone with a severe acute respiratory illness requiring hospitalization in the absence of an alternative diagnosis that fully explains the clinical presentation. And it's worth noting, just from this point of view, respiratory illness is counting as a fever plus at least one respiratory symptom, which is typically going to be cough or breathlessness. Moving on to probable cases, these are the people that are presenting as a suspected case, but where the testing has been inconclusive or where you couldn't perform a test. And finally, a confirmed case is someone who's had laboratory confirmation of COVID-19, regardless of what their signs and symptoms are. So if we think back to our patient, she's presenting with some of the features that we'd be concerned about. So we know that she's been exposed to someone that sounds like they've had symptoms within the past 14 days. And we're noticing that she has a dry cough. However, we've not been able to monitor her temperature, so we're not 100% sure. But certainly at this point, we're a bit concerned. All right, so you're about to go into the seclusion review. How are you going to approach this? What information are you looking for? What are your concerns? And how are you going to go about this seclusion review?
So send us your thoughts on approaching the seclusion review. Okay, so definitely want to check her respiratory rate. Safeguarding, yes, absolutely. Where is the key PPE? Yes, COVID can cause delirium, but keep an eye out for our next episode, although also a reasonable differential in this case as well, potentially. So we want to have PPE for us. We want to get a temperature from her. Discussions about aprons, which we'll definitely get into. How many staff need to actually enter the seclusion is a good question. So oxygen saturations, yes, absolutely. Eye protection for spitting. Oh yes, helpful advice. Thank you, Juliette. If you want everyone to see your comments, you can do all panelists and all attendees. Yeah. Right.
All right, so some useful thoughts in there. Let's have a look then. So the first thing that jumped into my mind was safeguarding. I think that's the first thing I would worry about here. So we know that she's got a young daughter at home, but we don't know what's going on with the daughter. Is she safe? Where is she? So that's certainly something we want to be looking into straight away. The other thing that jumped to my mind, and this is kind of based on a few cases I've seen this week, is about how accurate is the history that she's given. We can tell that she's got some delusional ideas about coronavirus, so I'm not sure how confident we can be about the history she's giving about her exposure to a cough. And I say this having had a patient who told us that she was self-isolating but really just didn't really want to go for her depot last week. So it is worth bearing in mind that this might not be an entirely accurate history. The other questions we're asking is how unwell is she? And that's really what we're trying to answer with this seclusion review. We need to work out whether she needs to go and get urgent medical attention, whether we can safely manage her in seclusion, and how worried we should be about her. And I'm also a bit worried at this point about how we're going to safely test her if she's as agitated as the nurses are telling us. Cool. I mean, another point that has come up is that there is a potential risk of lithium toxicity if she's been continuing to take her lithium and she's had a fever and become dehydrated. There is the possibility that her renal function's deteriorated and her lithium might be going up. And in the back of her head, as psychiatrists, we are wondering why she's relapsed at this time, having had quite a few years without any symptoms. All right, okay. So moving on, you managed to get in touch with her partner. You find a phone number on the patient notes and give him a ring and get some collateral history from him. And you learn that their 6-year-old is safe at home with him, so there isn't the immediate safeguarding concern that we were worried about. He does tell us that the daughter's been unwell for 5 days with abdominal pain, muscle aches, cough and a fever. So that is quite suspicious of coronavirus. Her partner's noticed that she's become really anxious over the past week or so. She's been really fixated on the news about coronavirus, talking rapidly, sleeping for only a few hours a night and acting out of character. And he also tells us that she developed a fever and a cough 2 days ago, and she may have stopped taking her lithium in the past few days as well. And he's not aware of any illicit substances. All right. So we're preparing for the seclusion review now. So the first thing we have to do is make sure the team is aware of the potential risk of coronavirus. Locally here, the first person we have to tell is the duty senior nurse, who will coordinate all of the getting PPE organised, getting all the swabs together. So that's my first port of call. Yeah. You want to get everything organised before you go into the seclusion room. So you want to avoid the need to be going in and out of the room repeatedly. So a bit of planning is involved there, as you would with any seclusion review. You also want to make sure there's bins immediately outside for safe disposal of waste. And you want to make sure that you've got every bit of equipment you could need. So before you go in, you're going to have a chat with the team about how many people are actually needed in the room, and you're going to agree on some goals for the seclusion review. And I think really our priority at this point is to assess her physical health and to get a sense of how agitated and aggressive she actually is. All right, so how much PPE do we need here? What do you guys reckon?
What is the full shebang? Hazmat suit.
Hazmat suit. That's quite an extreme reaction.
Column 2.
Column 2. So
yeah, we're definitely going within 1 meter.
Yeah,
aren't we? Well, we're hoping to.
Yeah, I mean that would be the aim, wouldn't it?
Yeah.
But we're certainly not doing any aerosol generating procedures.
Yes.
So at this point, we're thinking about disposable gloves, plastic apron, disposable mask, and not an FFP3 respirator for this. And we might consider eye protection as well, given the history of spitting.
Yeah.
All right. So this is what's recommended. But I think we have to stop and think for a minute that that's what's recommended in a general medical setting. We're obviously in quite a different scenario here with a patient that's potentially going to be quite aggressive, might be spitting, might be quite risky. NAPICU have put out some guidance, and they've looked at the viability of different types of PPE where there might be the requirement to restrain someone, and they have got some initial information out. So they're saying that face masks are quite effective. They're pointing out that spit guards and eye guards are effective, although they do point out that you might need another member of staff available to readjust them if the patient pulls the eye guards off. They have pointed out that aprons can be a bit of a hindrance in a restraint situation, and they can become a slip hazard. So that's something that you and the team will need to have a discussion about, whether they feel like it's going to be appropriate to use aprons in this setting. Scrubs are of course recommended. Gloves are also effective here. And there haven't been any tests about the viability of disposable overalls in a seclusion restraint setting yet, but it is something to think about.
I'm looking forward to overalls.
Yeah?
Yeah.
I think it'll be a good look. All right, the other thing we have to think about is how feasible it's really going to be to get these swabs off of her. We know that she's being agitated, we know that she's being aggressive. What do we actually need to do to confirm coronavirus here? Now, I do think it's worth trying, so worth going into the seclusion and asking her and talking to her about it and seeing if we can have any luck talking her into it. And if that's the case, then this is the recommendation for diagnostic samples. I know locally most of our nurses now are pretty confident and have been trained in using this. Ideally, you want a nose and a throat swab. And they are recommending that if you can get a sputum sample, you can, although we know that Our Lady here has a non-productive cough, so that's not likely to be possible. And these recommendations come from A&E, and they're recommending that if you're admitting the patient, you should also do a sample for acute serology. I think it's going to vary from place to place, but you might want to check your local guidance to find out if that's something that you guys are doing locally as well. Got a question coming in: will nurses be doing the swabbing, or will they refuse and ask the doctors instead? Certainly in my experience so far, the nurses have all been pretty comfortable doing it, and it's not really been an issue. They've all had training in it now, so it shouldn't really be a problem.
Yeah. We've had a number of people swabbed in our ward, and no one's asked me to do any of it, so I think, yeah. But it looks quite unpleasant, actually.
Yeah, it goes right to the back of the, it's not very nice.
Yeah.
Some questions about the type of tube that you'd send off a serology sample in. It's a plain tube with no additives, so the colour will vary depending on what lab you're sending it to and what trust. Yeah, but it's the ones with no additives. All right. Okay, so our next step is to put on some PPE. We did cover this last week. I just put it in to reiterate that this is the order that you do it in. So hand hygiene, apron, gown if you're using it, surgical mask, eye protection, and then put your gloves on top. We have included a video in the links at the end if you want to watch someone donning and doffing their PPE. And I think it's quite helpful to watch the video a few times just to get your head around exactly what's involved before you have to do it in real life. All right. So you get into the seclusion room and you have a chat with Miss Cate. The first thing you do, of course, is explain to her why everyone is wearing PPE, because as you can imagine, it's probably quite alarming for a lot of patients to see everyone in their full gear coming into the room. In our patient's case, she's quite dismissive. She said there's nothing, absolutely nothing to worry about, and that nobody needs PPE because she doesn't have coronavirus. She's curing everyone of coronavirus. The staff offer her some food and drinks, but she says she's not hungry, and you leave some food in there for later. And initially, she says she doesn't want the viral swab, but after a bit of discussion, she agrees to have it because she thinks that we can use it to develop a vaccine. Now, I thought that raised an interesting point, actually, because she's consenting to it on the basis of a sort of delusional belief here. What are your thoughts about that, Cate?
Does she have capacity to consent? What do people think about whether she's really got capacity to consent to her viral swab? Capacity doesn't matter.
Oh, controversial.
That's just shared with panelists, I think.
Has no capacity. So generally people are saying no, some mentions of duty of care, best interests. And I think that's kind of what I had perhaps reached the conclusion of, because she's actually giving permission, but she doesn't really understand the reasons, probably isn't weighing things up appropriately. But this is obviously not something that we would do under the Mental Health Act because it's a physical health procedure, but it would be in her best interests really to know whether or not she has it. So that's kind of where I would be going and my interpretation, because it will affect her management potentially.
Yeah, absolutely. So she does let the nurses do the viral swab, and we decide it's a best interest decision here. And she does also allow a set of bobs. So we see her, well, I'll put it up on the next screen actually. So here we go. That's her set of bobs highlighted. And so we can see that she's got a new score of 2, which is not terribly concerning at this point. If anything, it's a bit reassuring. All right, so continuing on with the seclusion review, she's still elated, she's got pressured speech, she is a bit hostile when you interrupt her or challenge the delusions at all, and she is still talking in quite a grandiose way about being able to cure coronavirus without really any insight into the relapse. You ask a bit about the symptoms that she's been having. She's denying any additional symptoms apart from the cough. You do notice that she has a cough, but her breathing seems to be fine and she's still talking in full sentences. And you can see that she's not clinically dehydrated and you don't see any tremor or any abnormal movements. Unfortunately, that's as far into the examination as you get, because when you start trying to examine her further, she gets really annoyed, she pushes you out of the way and starts to try and stand up in the middle of the seclusion review, shouting that she needs to go, she needs to cure everyone, and we need to let her leave. And given this really agitated presentation, the team felt that that was an imminent risk of violence, and so they ended the review quite quickly at that point.
I think just some further comments about the MCA, MHA, I think a helpful comment from Chloe is just really importantly, and this is very relevant in terms of coronavirus, is that MCA is about the person's best interests. It's not about protection of others. That's where maybe the Coronavirus Act might come in, but that's probably not relevant in this sense. So, you know, we probably can use the MCA to test her.
Yeah. All right. So you finished your seclusion review quite quickly and quite abruptly, and now you have to remove all your PPE. And again, I'm just reiterating this is the order you do it in. Hopefully you guys are pretty familiar with this by now. All right. So after the review, obviously the first thing you do is have a bit of a debrief with the team about how it went and discuss with your seniors and with infection control. And then we start to formulate plans. So at this point, what do you guys want to do?
So again, some comments about the Notifiable Diseases Act, and there is, which we'll kind of touch on later, to do with the Coronavirus Act, potential to hold people and test them. But because she's got a mental disorder and that's affecting her decision making, we're kind of using the Mental Capacity Act and the Mental Health Act because that's the most appropriate laws to be using.
Yeah. And we will talk a bit more about the legal basis later on.
So thoughts about whether she should come out of seclusion or not. People are saying probably no, she's still a risk to others, violent, need to give her some medication potentially, one mention of olanzapine.
All right, so let's talk about medication then. What are you going to do about medication here? So we've got one mention of olanzapine. Anything else that you might think about here?
So some olanzapine, some paracetamol. Don't want to give her lithium. Questions about lithium toxicity, or should we restart lithium? So a mix of ideas.
Yeah.
Yeah, some ideas about lorazepam and benzos and whether that's safe in coronavirus.
Yeah, fair enough. Well, let's go on then. So pretty much in keeping with what you guys have been saying, there's some question about the safety of using benzos in people with coronavirus on the basis that if their coronavirus symptoms deteriorate and they're on benzodiazepines, then there's an increased risk of respiratory depression. And that can be potentially quite risky. NAPIQ guidance at the moment, and also ELFT's guidance, which came out last night, are suggesting that if you absolutely have to use a benzo, then lorazepam's your best bet because of it's got the shortest half-life. But if you are going to use it, then definitely make sure you have fumazanil on hand. I mean, I would hope that you would anyway, but I think in this circumstance, be absolutely sure that you know where it is before you think about giving any lorazepam. The guidance also says that promethazine is something you can consider as a sedative, but obviously you have to bear in mind the potential for QT prolongation. Lithium, I think I agree with most of you guys here saying that you probably wouldn't want to start lithium right now, partly because of concerns of potential toxicity, and yeah, partly because it's not going to have an immediate effect within the next 24 hours in seclusion. So certainly something to think about further down the line. And she's got a fever, exactly. Lots of reasons not to give lithium right now. Moving on to antipsychotics. So of course, there's always the risk of cardiac complications and NMS with antipsychotics. And that's going to be a bit harder to pick up on in a febrile patient. NAPIQ is recommending olanzapine is probably the best choice, but obviously remember that you can't give IM olanzapine or lorazepam at the same time. You should be leaving an hour in between administration of the two of those. So do bear that in mind if she's refusing oral and you have to think about IM. Thinking a bit about paracetamol, the recommendation at the moment is that you can use paracetamol in people that have fever and pain, but they're not recommending that you use antipyretics just for fever on its own right now. All right. Moving on. All right, so your plan with medication then is that we're probably going to start her on some olanzapine and potentially think about some benzos as well, although we might hold off on those for just now, just until we get a better sense of her respiratory function. At this point, are there any other tests or investigations that you want to do?
Hello?
Is anyone there?
Okay, one vote for blood cultures, bloods, some FBE, UNEs, CRPs. Yes, we did say that she's got asthma.
Yep.
Yep, CRP, urine, ECG if we can, peak flow possibly, LFTs, urine, pregnancy test, very good.
Yep. Lots of the important ones we think about. So these are the recommended bloods for someone with suspected corona. And of course, I haven't put this on the slides, but we'd include a lithium level as well if we could get it timed about right. And they recommend in severe illness to add in CRP, procalcitonin, PROP, LDH, and CK. A few people have already mentioned the pregnancy test and UDS and urine dip. ECG recommended if she develops chest pain. Would you want to do a chest x-ray? Is that going to be feasible at the moment?
Generally a no on the chest x-ray.
Fair enough.
Yeah, absolutely.
So, bit of a consensus there.
So clinically she's not really in respiratory distress at the moment, so we wouldn't be moving her around anyway, and it's not likely to add to our treatment at the moment. So yeah,
I think that's fair. I do think discuss with the med reg if you've got any concerns, but I'd be inclined to avoid a chest x-ray for now. All right, so how are you going to monitor her physical health while she's in seclusion? So we're in a situation where we've got a patient, we suspect corona, she's quite agitated and does need to be in seclusion, but what kind of advice are you going to give to the nursing staff that are on one-to-one with her over the next couple of hours?
So definitely respiratory rate, excellent. Yeah, news score. So 1 vote for TDS OBS. So do other people have thoughts about how frequently she should be having her OBS done, whatever those OBS may be, 4 to 6 hourly, QDS, 4 hourly?
I suppose what we're trying to balance up here is the risk of exposing staff and the risk of violence if they have to repeatedly enter seclusion against the risk of her deteriorating.
So that's a,
a bit of a mix there.
Yeah.
There's some quite helpful guidance from BMJ Best Practice, where they've suggested some things that you can look for if you're doing a telephone consultation. And I thought some of that advice is also quite helpful if you're watching someone through a seclusion panel, as things just to look out for. So certainly, as I finish this seclusion review, I'd be talking the nurses through all the things that I want them to watch out for. I want to know the state of her breathing. Is she still able to talk in full sentences? Is the colour of her face or her lips changing? I'd also want them to keep track of what her fluid intake is, and that's easy enough to do in seclusion where you know how much water you've left in the room and you're observing non-stop, so that's something they can keep track of quite well. And you want to find out if she's having any pain or discomfort as well. You'd also want to have a really clear plan with staff that they know they can contact the duty doctor if anything deteriorates or if she's developing any red flag symptoms. What are your thoughts on red flag symptoms? What would you be telling the nurses to look for here? Shortness of breath, yeah, definitely.
One mention, which some of you guys might have seen going around on Twitter, this idea that you can kind of remotely assess someone by asking them to count to 30 in their native language. So we're also looking for respiratory rate again, increased work of breathing, any confusion. Yeah.
So these are the red flags that the BMJ suggests that you look out for. I think that's a good starting point, although you guys have got some good suggestions in there as well. But certainly highlight to the staff that if any of this starts happening, they should be calling you straight away to discuss. Yeah. All right, so over the next few days in seclusion, she does quite well on the oral olanzapine. She does take it orally, and she does eat and drink reasonably well, although she's still being quite verbally threatening towards staff. She still has a cough and a fever, but she's not developing any new symptoms, and her OBS have been reasonably stable and consistent. We still haven't got the COVID results back yet, so we don't know yet whether she's positive or not, but I think at this point we're working on it as a presumed case. By her 3rd day in seclusion, she's still a bit irritable, she's still shouting, but she's definitely not as hostile as she was when she first came in. And her BBC score is 1, and for those of you outside of ELF, that's equivalent to a MOS score of 1. She's still quite disinhibited and elated, and she's still pressured in her speech. And she still thinks that she can cure coronavirus by touching people. And she's still trying to reach out and grab onto staff to help them out and cure them when they go in for reviews. So at this point, we can see that she's beginning to get a little bit better. But what are your thoughts now on terminating seclusion? What kind of criteria do you have here? And also, when she does come out of seclusion, what are you going to do about her?
So where should she go? Where should we be aiming to move her to if she does come out? So thoughts about isolation on the ward, isolation in her room, or an isolation ward?
Yeah.
So that may vary depending on what your trust has at this point in time as well. So a few of the options are obviously to go to a COVID ward, like an isolation ward, or to isolate in her room. But it sounds like we think she's still very much within the 7 days.
Okay. Yeah. So as Cate said, that there's going to be some sort of variation depending on what you have locally. But I think when we're thinking about any sort of restrictive intervention, whether it's segregating someone in a specific part of the ward or whether it's isolating them in their room, we have to remember that even in a crisis situation, we have to think about the dignity of our patients. We have to make sure that things we're doing are proportionate and in the patient's best interests, and that they're actually evidence-based. And really what we're aiming for here is to work really collaboratively with this patient so that we can reduce the need for restrictive interventions going forward. Okay, so just thinking very briefly about the legal basis for these interventions. This has been touched on already, but the first thing we should be doing if someone's not able or willing to comply with our infection control suggestions, the first thing you should do is assess their mental state and their capacity and write really thorough documentation about that. It's already been highlighted that MCA and DOLS is something you can consider, particularly if there's a risk to the patient themselves, but remember that you can't use the MCA to protect others. That's a really important point to remember. So in our case, the patient is not compliant with infection control because of her mental illness. She's got delusions about being able to cure people, and that's why she's touching and trying to help people and placing them at increased risk of catching the virus. So in this situation, we include that as part of our assessment of risk to others as we normally would with the Mental Health Act. And so in this particular patient's case, the Mental Health Act is the most appropriate framework. That being said, if someone's presenting with refusal to comply with isolation procedures and it's not related to either their mental illness or their capacity, you can't use the Mental Capacity Act or the Mental Health Act. So at this point, it falls under the Coronavirus Act 2020, which grants the police some additional powers to detain people. And so the first thing you should be doing at this point is calling up the police to discuss things further.
So there's just some questions about whether she's had the result of the test.
Here we go. So we move on to the next slide. So we're now 3 days after the test. I don't know about you, Cate, but I've been finding we're getting them just under 72 hours after we send them off.
Yeah, getting there.
Yeah, so 3 days seems to be a pretty standard thing around here at the moment. So you do chase up the test results and you find out that, not unsurprisingly, she tested positive for coronavirus. At her next seclusion review, she's still calm. There's no further aggression. She's still a bit disinhibited, but the MDT does feel that seclusion isn't really appropriate or necessary anymore. So you discuss with your seniors, you discuss with infection control, and she's transferred to a hot ward for further treatment. So hot ward, we mean COVID positive ward for patients that have tested positive to coronavirus.
Oh, sorry. There was just one question about whether or not we would report her to the police. And I think, as we've kind of explained, because she meets the criteria of the Mental Health Act, then that the kind of Coronavirus Act is sort of irrelevant in this case, because the Mental Health Act is the most appropriate legislation to be containing her under. If she was someone who, I don't know, I mean, I imagine the Coronavirus Act was made for people who do not have a mental illness but are refusing to kind of adhere to the kind of isolation and testing, that's when the police would get involved. So no police for her at the moment.
No, certainly not. All right. So locally, we have set up hot wards for people that have coronavirus positive results. The advice from NAPICU and from a few other organisations is that if you don't have hot wards set up locally, you should be trying to segregate them in a designated COVID section of your ward. So you should be trying to keep all the COVID patients in one place and separate from the rest of your patients, if at all possible. All right, so she's doing reasonably well, and 7 days after her symptoms started, her fever and cough have resolved and her OBS have been stable. She's still mentally not 100%, she's still a bit grandiose, but she is managing all right to isolate herself in her room. And although she's still trying to cure people, when staff put boundaries in place and ask her not to touch them, she can comply with that. So at 7 days, you get a call from the ward manager. The hot ward is short of beds and they want to admit another patient. And so the ward manager wants you to assess and let you know if Miss K can be transferred off the hot ward yet. What do you guys think?
So a question about how long she's been fever-free for. So
I didn't specify that, but let's say 48 hours.
So some votes for 48 hours that she needs to be symptom-free or fever-free or cough-free. Does she need another swab? Good point, can't be cough-free. The cough goes on for a long time, potentially. So there's some disagreement between guidance between WHO and Public Health England. And a question about paracetamol masking the fever, which is also a good point. Right, so should we move on?
Yeah, so in Our Lady's case, she's been fever-free for 48 hours, so she does meet the criteria. As Cate said, there is a bit of discrepancy between what the World Health Organization is saying and what Public Health England is saying. But certainly within England and within our local trust, the recommendation is that if someone's asymptomatic at 7 days and fever-free for 48 hours, then they are okay to come off the COVID ward. So you discuss with infection control and with the matron, and they suggest that take her off a hot ward and send her to a warm ward, which is a ward for people that may have COVID but aren't confirmed. So she's moved to the warm ward and managed on 15-minute OBS. All right, so 3 days later, we're now at 10 days after the onset of her COVID symptoms. She develops abdominal pains and diarrhea, and you're asked to review her. What are you guys going to do now?
Maybe just summarize what's happened.
Yeah, I can't remember what happened.
So she's now on the warm ward, and she has been symptom free, but she's now developed new symptoms, which is essentially day 10. So abdominal pains and diarrhea. So questions: has she got C. diff? Does she need to isolate again? Starting again at the beginning with a history and examination. Wearing PPE, very important point. And a point about COVID potentially reoccurring. And yeah, question of whether this could be COVID or could it be something else. Yeah. She hasn't had any antibiotics. So unlikely to be C. diff, but there could be another infectious cause of diarrhea.
Yep. So on advice from infection control, you keep her on the current ward and isolate her in a room for 48 hours as per the DMV infection control policy. It's certainly been noted that people are having a second spike in symptoms with COVID a little bit further down the line, but at present the advice is just isolate her in her room. And actually the DMV resolves quite quickly within 24 hours, so we're quite reassured by that. So her mental state is improving a little bit, and she appeals against her section. She's saying that she wants to be discharged so that she can get on with ending this pandemic, which is something I can really, I'm kind of on board with in some ways. But it does raise some interesting questions. Has anyone had any experience yet of a new mental health at tribunal during a pandemic?
So tribunals by phone, 2-hour hearing last week somebody had. Wow, okay. By Zoom, dial in. Let's hope nobody Zoom bombed that. So yeah, absolutely. Basically, it's all still
Yeah, absolutely. So there has been some advice out on changes to tribunals now that we're in a pandemic situation. The judiciary is saying that they're going to prioritise Section 2 and conditional discharge hearings, but they will try and continue with other tribunals as well. And as everyone's saying, we're going to be doing dial-in tribunals for the foreseeable future. My first one on Friday. I'm really interested to see how it goes.
You can update us next week.
Yeah, we can do an update next week on that. What we know is going to happen is that patients will no longer have a pre-hearing examination by the medical member. For the tribunals that had already been confirmed before this guidance came out, they're going to go ahead with the full tribunal panel, but do it by telephone. But as of last week, any new tribunals that have been arranged will just be listed before a single judge, and it will all be carried out by telephone. If the patient decides to be unrepresented, then they may have the opportunity to speak to the judge on their own, but that's left to the judge's discretion. And the judge can consult a medical member if they feel like that would be helpful. Some people asking
about leave. So that's worth discussing with your local it can be variable across trusts, but it does have to be really in keeping with the current guidance from the government about how much leave any of us are allowed out of our house. So most places, certainly here, we're having only 30 minutes once a day for everyone. If someone's informal and isn't complying with that, then that might be a time to be thinking about discharging that person.
Any comments? All right, so that's all we've got time for this week. we'd really love you to just summarise any useful learning points that you think you've taken from this. So do type them into the chat if you've had any interesting learning from here. And we've got a few minutes now for some question and answers, so please do send your questions in.
Can we force people to isolate in their room under MHA if infection risk to others, or do you need seclusion? What do you think?
So the question there, can you force people to isolate in the rooms under the Mental Health Act if there's an infection risk to others? And if so, do you need a seclusion protocol? I mean, it's a good question. I mean, it's the same. I don't think you treat it any differently to any other infection risk. So if a patient had DMV, or if they were HIV positive and spreading the blood everywhere, you would consider that a risk to others, and you would manage appropriately. Is it proportionate to isolate someone in the room? I think in a pandemic it probably is.
Yeah.
And I guess the need for seclusion protocols depends on your local trust, really.
And I suppose the less restrictive option would be to have someone nursed in their own room rather than being in seclusion. So that would still be less restrictive.
Yeah.
So I guess, you know, that's segregation. Yeah, segregation rather than seclusion.
Yeah.
Yeah, keep scrolling down. Questions on, okay. Yes, slides are going to be shared as with the whole webinar as well. What else? Okay. I don't think, do we have any updates about testing staff?
Testing is, well, I mean, you have to ask Boris that one, I think. One for Boris.
So it's also a good question, and I think it's something I've been wondering about myself, is kind of hot ward staffing and warm ward staffing and kind of mixing. And obviously one of the things that's come up with kind of other medical wards is about sort of duty doctors moving around and having to cover multiple wards. So obviously on the medical wards, they're trying to keep a hot ward staff and a cold ward staff and so on, and not mixing them up. I think there is an argument for us doing that as well, but I think we await further guidance. But yeah, it's a good point about not coming and going off those hot wards.
I think there's a lot of movement at the moment in terms of changing wards, certainly at ELFT, looking at cohorting patients. So possibly there'll be quite a few more changes in terms of staffing in the next few days, certainly at ELFT.
Yep. Question about use of SATs to differentiate between anxious, respirate, and genuinely short of breath. Yeah, absolutely. I think, you know, if someone's just agitated but has a normal lung function, then I guess their SATs should be normal. Yeah. What do you guys think?
Yeah, I agree. I think it's a pretty sensitive way of differentiating.
Yeah. I think great point from Leader about when if you're admitting an informal patient, actually explaining that they will have restrictions around their leave, so that they can actually consent to that deprivation of their liberty, and also just to give them a heads up, because obviously they'll get a shock when they get to the ward, and be surprised and might get upset. So I think that's a really good thing when you're clerking people in A&E, actually to tell them that they won't be having very much leave. I'm a bit confused by that one.
What's the question?
Oh, reinfection. I don't know the answer to that question.
I suppose the question is around if staff have had coronavirus confirmed and then they come back to work, is there a concern that they can get reinfected, or vice versa with the patients? You know?
Yeah.
I mean, I don't think there's a clear answer on that yet. I know there's a lot of research going into it, and it would be very helpful to know.
Yeah.
But at the moment, I don't think we really have a clear answer.
Yeah. Just a question about highly probable cases who tested negative. I think there is some advice on that, because there can be false negatives. So I think there is some Public Health England advice on kind of retesting people, but also if they're highly suspicious, you treat them as if they have COVID until sort of proven otherwise. So yeah. Do you want to address the social distancing? You got
Yeah.
59, we can't keep up.
Yeah, you guys are sending a lot in. We're being told off because we're not practicing social distancing. I guess
Yeah.
we looked at the risks and benefits and felt that
we're already coming to work together anyway, so
Yeah.
it's kind of, yeah, what can you do? But yes, it's a good point. We would love to use computers in separate rooms, but it would just be impossible, I think. So yeah.
right, and we do also have a Q&A section up here.
Yeah.
What
So I
are
think
the
that's
questions?
do you want to read out?
So we're just struggling with the long questions that have been sent in. So we've got a question from Dave Bailey. In the community, I have several patients who are low grade, chronically unwell, not presenting a level of risk that would reach threshold MHA, but not adhering with advice to self-isolate.
So we are doing a community case week after next. I think we've got a CMHT based case.
Yeah.
Where we might try and address some of those questions.
Yeah, lots of other issues in the community. So yeah, we'll have a look at those in the next couple of weeks.
Yeah.
Thanks.
What are the others? Questions about scrubs, which I think is helpful to raise locally.
I don't know if anyone saw the memo from Dr. Galuli yesterday. So scrubs, I don't know if it mentions scrubs, but I know that scrubs are being considered, and I think the supply is the main issue at the moment, but it's not something that the trust are against at all. So hopefully they will come in time.
And question about someone with dementia, which is great because we're going to try and do a dementia case next week. So hopefully we'll try and discuss those at that point. Do you want to address the question about paracetamol? Do we have time?
Yeah.
I think, so the advice is not giving paracetamol for fever only is, I guess, essentially because we don't need to treat a fever.
Yeah, and we'd just be masking the fever.
Yeah, but if someone's got pain, we obviously don't want to leave them in pain. You might have seen that some people are actually overdosing on paracetamol at home because they think that there's a treatment for COVID. So that's also something to actually ask your patients about when they come in. But yeah, just for only if there's pain.
And while we're talking about analgesia, it's probably worth reiterating that at the moment the advice is to avoid non-steroidal anti-inflammatories. Certainly not to prescribe new NSAIDs in patients that don't have any, and then with patients that are already on them to consider the need for them.
And yeah, some other questions about community-based patients. So I think definitely we will be doing that.
Absolutely.
In a couple of weeks' time.
Watch this space.
But don't let that stop you looking up the guidance yourself.
Please don't wait on us.
I think there was a question from Deepa about transferring to emergency department, and that was covered in last week's presentation. So do have a look at the link that was on these slides to last week's presentation.
Yeah, that's okay. All right.
I think that's probably all we have time for today.
Guys, I just want to thank Cate and Lynsey so much for putting all of this evidence together. These guys are doing a lot of work during the week to put the available evidence together as it comes up, but also say thank you so much to everyone for sharing all your knowledge. I don't know about you, but I mean the amount of knowledge has expanded so much in the last week from all of you guys as well. So hopefully you're finding this useful, and do let us know if there's anything you want us to do differently in future. But thank you so much for joining us.
Yeah.
Look forward to next week.
Yeah, and just a final point, I think Charmin will be putting a link into the chat with a feedback form and some room for comments of suggestions of things you'd like to see in future case presentations. Please do keep sending them in. We have been getting a lot of suggestions in, and I appreciate we're not able to cover absolutely everything that you want straight away. We're trying to prioritize the stuff that might be helpful in an acute on-call situation. But please do keep sending your ideas, and we will try and cover as much as we can in the coming weeks.
Yeah.
All right.
Cool.
Thanks everyone, stay safe.
See you next week. Bye.